if you wanted to press. Okay, so we're all being told this meeting is being recorded. That's great. So hello everyone, and welcome to you from wherever you are in the world. My name's Sarah Edwards and I'm a ST5 in emergency medicine, and I'm also doing a paediatric emergency medicine educational fellowship, and I'm based in the East Midlands in Leicester, and I'm snowed in currently, which is very exciting. So I'm going to do a series of talks with you over the next coming weeks on sort of some of the diagnostic things that you might encounter. And this ECG talk is a pair of talks. So what we're going to cover, hopefully in the next hour, is physiology, some ECG basics, and a little bit of a systematic approach to the interpretation of the ECG. Now, it is a challenging topic, and we've only got just under an hour to cover this topic, but at the end of the talk, once you've filled in your feedback form, which will get popped in the chat, you will be sent the slides, and will have access to the slides. So don't worry too much if you don't remember or can't jot everything down. And also this talk is being recorded. So between all the Zoe and Jamie will be able to share that out to you as well. So to bring a little bit of interactivity, I'm sure some of you have used this before. I'm going to use menti.com. So if you've not used Menti, or if you have used Menti, can you go to menti.com on a different device, a phone, iPad, whatever you've got, I don't really mind, and put this code in that's on the screen. Don't worry if you don't remember the website or the code. When we get to the slides, we will see the code again, so don't panic about that. So if you go to menti.com, put 8477058 in, it would be great to just understand the range of years of medical school students and anyone else that I have here. So if you're able to type in and answer that, that would be really, really helpful, just to give me a flavour of sort of the level of the audience that I'm talking to. That would be great. So I'll just give everyone a moment just to do that, and hopefully with the wonders of technology it will work. So if you go to menti.com and then put 8477058, and it'll take a minute or two for it just to catch up. So hopefully soon we'll get some people. If not, not to worry. If it's a completely different question on Menti, that's fine. You should be able to scroll back and forward through the questions, but don't worry. We'll move on, and that's fine. Let's see if this one will let you answer, which is, what one thing would you like to know about ECGs? Now, you should be able to scroll on Menti through the questions, and I'll just reload it here to see if this will work. It's not the end of the world if it doesn't work, but we can use the chat box in a slightly different way.
It's just changed, it's working now.
Yeah, that's it. Brilliant, great. So brilliant, just needed to reload it, that's fine. So we've got lots of things, so how to interpret them, axes, everything, please help. Oh gosh, I'm not sure I can quite, that's quite impressive. Bundle branch blocks, let's have a look, let's give everyone a second. So lots of things here, so about general knowledge, interpretation, everything from bundle branch blocks, SVT, lots of different rhythms, and things like that. So some of these things I'm going to cover tonight, which is a lot along the lines of a little bit of background knowledge, a little bit of anatomy, a little bit of physiology. Some of these things I'm going to cover next week for ECG part 2, and that will be more around
for you as well.
That will be more around rhythms, rhythm recognition, common rhythms that you need to be aware of, and things like that. So that's really helpful. Thank you. So a little bit of anatomy and physiology, so don't worry, I'm not going to dwell on this too much, but I think it's useful for you to get a flavour of what is important. So going to keep it really simple. This is a heart, and hopefully you're aware of that. And really key things to be aware of with the heart, particularly when it comes to the ECG, and this will become apparent as I start talking to you, is aware of the SAN, so the sinoatrial node, the atrioventricular node, and the electrical activity carrying on down through the bundle of His, through the Purkinje fibres, and into the right and the left bundle branches, sharing that electricity. Just have this heart diagram in the background, and we're going to touch upon this in relation to the ECG, so don't worry. So the ECG, you either love it or you hate it, probably a little bit like Marmite, and this is the normal ECG. And the ECG is a mix of a lot of letters. So you've got to love medicine. You know, you start in medical school learning about A, B, C, D, E, and then for good measure, we chuck in a bit of PQRST. And so this is the normal ECG. And with all of these letters that we've got thrown in, we've also got some intervals, and we've got some segments, and we've got durations. So we've got PR intervals, QT intervals, ST intervals, we've got waves, we've got segments, we've got all these other terminology. And one of the things when I was thinking about when I was writing this talk and using Zoe just to check that, you know, we're aiming for the right things, is the challenge about what all these different things mean. And I think until I'd probably qualified, when I was an F1, F2, I slowly started to appreciate what some of these things meant. Now I'm going to go through each of these intervals, each of these waves, and talk a little bit about them. I'm not going to go too much into detail about the clinical applications of them in this talk, but that will become relevant in next week's talk for ECG Part 2, where the common arrhythmias and rhythms and all the things that you should know or aim to know by the time you qualify will come to share upon, and I will relate some of this background knowledge to that then. So let's see, hopefully this is working. So what does the P wave actually correspond to? The P wave correspond to, and it still should be the same code. Great. And what I'm going to do is I'm just going to hide the results so we can see what's I can see what's happening, but they're going to be hidden from you. So we'll see what everyone says now in the background. Just giving it a moment there just for it to catch up. We've got 120 people now. Let's have a look. Let's see what it looks like. Okay, so I think most of you have got the right answer there, which is great. Let me move on to the next slide. And I'm just going to hide the results here. So what does the QRS complex relate to? And I've hidden the results this time, so there's no cheating or sharing of the answers. Great, thanks for right. Please don't draw on the screen. If you can use Menti, that's great, or if you can use the chat box, that's equally fine, but I'd rather not have random scribbles across the screen if possible, please. Let's have a look and see what everyone says. So yeah, so talking about ventricular depolarization, contraction, things like that. Okay. And then the next screen, let me just clear the annotation. So, and the last one that I wanted to talk about is, what does the ST segment relate to? Don't worry, I'm going to walk you through each of these parts of the ECG. Okay, let's unhide the results. So I love watching this on Menti. It just makes it very much more interesting just to see what everyone's thinking. Okay, so let's walk you through the ECG. Let's get you to learn the other end of the alphabet in relation. So the P wave. So the P wave is the first positive deflection on the ECG, and it represents atrial depolarization. And typically the duration is less than 0.12 seconds. When you think of the P wave, often one of the arrhythmias that is most associated with the P wave, or absence of P waves, is atrial fibrillation, and this will be one of the things that I'll be talking about next week. So that's the P wave. The next thing is the PR interval. So the PR interval is the time from the onset of the P wave to the start of the QRS complex. And it represents that transition of that electrical current through the AV node. And ideally, you want a short PR interval, and you know, so that's 0.12 to 0.20 seconds in duration, or 3 to 5 small squares. The PR interval becomes useful when you're thinking about heart blocks, for example, so first degree, second degree, and third degree heart blocks, again, of which we'll touch upon next week. Moving on in our alphabet of the ECG, we've got the PR segment. Now, actually, the PR segment we often don't think really much about. And it's something that I've only sort of appreciated now that I'm qualified, but it's usually the flat bit of the segment between the end of the P wave and the start of the QRS complex. And why it's useful is that it's associated with some conditions that you may be aware of, such as pericarditis, and the PR segment changes in that. And sometimes if you've got some atrial ischemia, the PR segment can move with that. The Q wave. Now, the Q wave, we've often hear a lot about the Q wave, and the Q wave really is any negative deflection that precedes, so is before an R wave, which is usually a positive deflection. So the Q wave should be negative, and there are lots of conditions that cause Q waves to be present, or deep Q waves. Sometimes they're normal, depending where they are. But actually deep Q waves, particularly in the limb leads, particularly in lead 3, if you've got deep Q waves, might suggest an old STEMI or an old myocardial infarction, and that sometimes can be residual and be left there. So Q waves are important to look for and think about. The next bunch of letters in our little alphabet soup are the QRS complex, and the QRS complex you either love or you hate, and as we talked about in the questions that you kindly answered, it's that ventricular depolarization. A normal width is sort of 70 to 100 milliseconds, so and you can have it slightly broader in those fitter individuals. And it can be useful in helping to determine where the origin of any arrhythmias come from. So thinking about atrial, junctional, ventricular arrhythmias and the morphology around those. Now, that's quite high, you know, that's quite sort of postgraduate stuff, but just to be aware of, that's why the QRS complex is important, but also thinking about your tachyarrhythmias. So, you know, your narrow complex tachyarrhythmias, your broad complex tachyarrhythmias, so things like your narrow ones being SVT, so supraventricular tachycardia, or your broad complexes such as your ventricular tachycardias. And there's lots of other different types of those types of complexes that affect the QRS morphology, that will, some of them of which we'll touch upon next week. Continuing on the QT interval. Now, the QT interval is basically the time from the start of the Q wave to the end of the T wave. And as it says, it represents the time taken for ventricular depolarization and repolarization, effectively the period of ventricular systole from the contraction of the ventricles to the isometric volume relaxation. Now, the QT is affected when you're calculating it by the rate, so the speed at which the heart rate is. So there is you have to correct for that, and there is a form, there's many different formulas for that, and it's one of the things that when you're an F1 or an F2 and you're working on the hospital wards, that you learn with something like MD Calc, which is an app to correct for the QTC, to have the corrected QTC. Really important for sudden cardiac deaths. There's lots of syndromes that are related to that, so prolonged QT, and thinking of torsades, and there's lots of other conditions that cause prolonged QT, and you can actually get short QT and you can get very short QT. All of these are associated in young people with sudden cardiac death. And really important that if you're spotting either a long or a short QT, that you're thinking about those risks that are associated with it. And the ultimate risk with a long QT or a short QT is it puts you at risk for ventricular abnormalities and arrhythmias. So particularly VF, VT, which are never good arrhythmias to have. I'm not going to dwell much more on QT interval and why it's important, but and some of this we'll probably touch on a little bit next week, but just be aware the QT interval is really important, and if you can practice calculating it, that would be great. The R wave, gotta love a good R wave. So it's the first upward deflection after the P wave, and it essentially represents the early ventricular depolarization. There are many things associated with the R wave, and actually what you're generally looking at when you're looking at an ECG for the R wave is the R wave generally getting bigger as it's going across the chest leads. This becomes particularly important in things when you're thinking about left ventricular hypertrophy, so you know, enlarged hearts, and you know, ischemia can affect this R wave progression, and there's lots of other conditions, but just to remember why the R wave is important. So next along in our little alphabet soup of ECGs is the ST segment. Now this is probably one of the most famous bits of the ECG that we're all taught about and all become intimately familiar with, and that's the ST segment. So it's flat, it's isoelectric section of the ECG, and it's between the end of the QRS and the beginning of the T wave, and it represents that interval between the ventricular depolarization and repolarization, so that very quick point. And there's something called the J point. Now, the J point, or the junction, is basically just that recognition of that termination between the QRS complex and the beginning of the ST segment. And it's quite a good demarcation between that, and depending where that J point is, because it can go up, of course, in ST elevation, for example, or it can go down as well in inferior MIs, and that can move around. But it's just a point at where that transition is. The next one is the T wave. We're slowly coming to the end of our alphabet soup. And this is the positive deflection after each QRS complex, and it represents that ventricular repolarization. It's usually should be upright in all leads, and it's usually quite small, so less than 5 millimeters in the limb leads and less than 10 millimeters in the precordial leads. Why T waves are important is if they're absent or they're inverted, this might suggest ischemia. And they come in lots of different shapes. So you can have hyperacute T waves, you can have inverted T waves, you can have camel hump T waves, you can have flattened T waves. All of these, as you go through your medical training, you will get more familiar with, depending what jobs you do. But it's just to make you aware of the importance of the T wave. And actually, one of the most important things is if they're starting to invert and they're inverting across lots of leads in the context of chest pain, this might suggest that there's some ischemia or an end STEMI might be occurring. And lastly is the U wave. Now the U wave you might not have actually heard of, and I'd never heard of it really until I'd qualified. So the U wave is basically a small bump after the T wave, and it's usually positive, and it's always in the same direction as the T wave. So if the T wave is positive, it should be positive. Sometimes you can see it, sometimes you can't, and the jury is out really as to what causes the U wave. But the U wave can be useful in lots of conditions, and appears in lots of conditions, things like hypokalemia, so low potassium, low magnesium, so hypomagnesemia, can appear with drug ingestion and things like that. And it's just to be aware that there is a different bump, as in the U wave, which is different from the P wave, because the P wave will be a lot bigger than the U wave. And again, it's just to make you aware of it. It became a new letter that I didn't realise, or a new part of the ECG when I graduated, and I was like, oh, what's this U wave? Doesn't hugely affect what you do, but you will start to see them the more patients you start to see and the more ECGs you look at. So that's a walk through the alphabet in the terms of the ECG, but actually what does that mean? So let's put this together to help you visualize the physiology, the electrical activity going through the heart, and what that means for the ECG. And the reason why this is really important to learn, not only do they like examining it at undergraduate level, but they absolutely love it in almost every basic science exam for every specialty, because it's great to test your knowledge of that understanding and that intertwining between the physiology, the anatomy, and what the ECG changes are. And even now that I'm towards the end of my training to be in emergency medicine, we still get asked this in our final exit exam, which is why it's really, really important that, if you can slowly begin to love the ECG and the physiology, it will help you going forward. But also clinically, it has great impact if you're seeing an ECG and you don't know what it means, and it allows you to think about, well, is this coming from the atria? Is this coming from the ventricle? Where is this coming from? And it just helps just to put that context on it. So we start at the beginning with the SAN that depolarizes. It initiates that atrial depolarization, and this occurs at the end of the isoelectric line. Moving forward, the atrial depolarize, and the P wave represents that atrial depolarization. As the AVN depolarizes, it occurs within response, and it's responsible for most of that PR interval that we were talking about. And thinking about heart blocks, for example, which as you get through your heart blocks, your PR interval lengthens, and then you eventually lose your QRS complexes. This is where issues around heart block begin. You've got ventricular depolarization, which is that QRS complex, which is travels down those Purkinje fibers through the bundle of His and pops out the other side, giving you that QRS complex. And finally, when that ventricle repolarizes, you get that T wave, and you might get your U wave as well. So just going to take a moment there just to pause. I'm just going to check if there are any immediate questions in the chat at the moment. Let's have a look. Great. Okay, so what I'm going to do probably over the next sort of 20 minutes is take you through reading some ECGs. I'm not taking you through reading ECGs, but take you through some of the principles and some of the structures that might help you when reading ECGs, because they are a challenge, especially at 3 o'clock in the morning when you're given an ECG and you're like, well, tell me what that shows. So let me just reload this. One of the questions I wanted to ask you, again using Menti, is to really understand what are the important factors when reading ECGs, do people think? So lots of things there that people are saying, and I've just noticed a question in the chat box which I'll answer now for you as well. So what are the important factors when reading ECG? So lots of things we've mentioned. So we've mentioned rhythm, rate, is it regular, having a systematic approach, is there P waves, what the speed, checking the PQRST order, lots and lots of things that you're mentioning. And just going back just one step to the question in the chat box, which is there a good time in the cardiac cycle along the ECG where you, if you're going to give an electrical shock for DC cardioversion, you know, where do you give it? So yes, there is. When you're thinking about doing electrical cardioversion, and this might be because somebody is in SVT, so supraventricular tachycardia, and they've not responded to medical management, or they have got features, adverse features. So adverse features in the context of tachyarrhythmias are heart failure, ischemia, syncope and shock. So I always think about HIS when I'm talking about adverse features with any arrhythmia. So that's heart failure, ischemia, syncope. So syncope being I'm feeling dizzy, I'm going to pass out, or I'm going to pass out, and shock being hypotension, so low blood pressure, so less than 100 systolic. So if somebody has got, for example, an SVT or any tachyarrhythmia that is over sort of 160, 170, that we think is a narrow complex tachycardia or a broad complex tachycardia such as ventricular tachycardia, and they have any adverse features, what we will do with the defib is use the synchronized button, and that when you give an electrical shock, you give a synchronized DC cardioversion. And what that does is it makes sure that the electrical current is given at the precise point on the ECG to reduce the chances of going into VF and VT, or VF basically, so ventricular fibrillation, which is not a great rhythm to have, as I'm sure you're aware. The point at which the electrical is given, so it syncs up the R waves basically on that QRS complex, and it will give it just at around that point in the QRS cycle, so just after the P wave, it will then deliver the electrical charge usually. So that's what we're talking about is DC, so direct current synchronized cardioversion for broad or narrow complex tachycardias where there are adverse features, so HIS, so heart failure, ischemia, syncope, so feeling dizzy or passing out, or shock, so hypertension, and that's when we might use some of that. Don't worry if you don't remember any of that. The call's been recorded, this has been recorded, but also we're going to talk about it next week. So that's that. So you can shock with AF, and so AF is obviously, so atrial fibrillation is a irregular, narrow, complex arrhythmia. And again, if there are adverse features and you're within the right window for it, you can use electricity to do that as well. So AF is another reason. I've deliberately not mentioned AF when I was talking about it, because AF can be a little bit complicated, which we will come on to talk about next week. So going back to what we're talking about really now, which is reading ECGs, lots of you have commented upon lots of things such as, you know, rate, rhythm, clinical correlation, having a systematic approach, and all of those are really important. So this is the nice standard normal ECG, and just as a reminder, so the red circle is around all your limb leads, and the big purple circle is all your chest leads, so the ones that go across the chest, they're the 6 leads. Really important, think about the ECG paper and the timing, and you need to have the paper for the ECG is standardly set almost universally across the world at 25 millimeters per second, which means that 1 millimeter, which is one small square, is 0.04 seconds, and then 5 millimeters, which is that big large square, is 0.2 seconds. And this diagram, which I've borrowed from Life in the Fast Lane, which is a brilliant website, it's got loads of ECGs on it, like every ECG for every condition. I highly recommend using it, and lots of the ECGs in this talk I've taken from Life in the Fast Lane. Brilliant website, have a look at it, and it will take you through a lot of these things. So a systematic approach to the ECG interpretation. So overview, so thinking about how do you approach that ECG. So you want documentation and quality, so making sure you've got the right thing, you've got rhythm, frontal axis, limb leads, chest leads, and thinking about all your alphabet soup. P waves and the QT interval are really, really important things to think about when you're interpreting that ECG. And what will happen, which you might not believe, but as you start going through medical school and as you start graduating and becoming doctors and the F1s and F2s of the future, you will be doing this inherently, and you will be doing it more and more often. And as with anything in life, the more you see of something, the more familiar you will get with it, and you'll be able to pick these patterns up and recognize the patterns easily. So don't worry if you're in your first year, second year, and a lot of this at this point is going over your head, or you're just worried that, oh my gosh, I don't understand. That's absolutely normal. I was exactly the same. It takes, you know, a long time to get familiar and comfortable with ECGs. So just bear with it and practice, practice, practice. Any opportunity you've got on the wards or any opportunity you've got to look at ECGs, just have a look at them. And that's with the same with x-rays, with anything that's pictorial, you'll just get good at them with practicing, and get, you know, your seniors to have a look with you and just practice those interpretations. So documentation, and we briefly touched upon this, but, you know, name, date of birth, date and time of recording, check that the leads are labeled, paper speed. So we've talked a little bit about the paper speed and what that actually means. And make sure that, you know, the quality, it's not wonky and all over the place because it's a hairy person, or, you know, they're sweating and you've got half the leads missing. So really, really important to bear that in mind. Determining the rhythm. So lots of you mentioned about the rhythm, and rhythm analysis is really, really important. So one of the things that I picked up in medical school, which I do use even now to this day, is sort of thinking about, you know, having a mnemonic, which is not everyone's cup of tea, I appreciate, but thinking about ravenous raiders pillage Rome quickly. And what that is just to remind you, when you're looking at the rhythm, the things that you need to think about. So the rhythm of the ventricles, are they regular or irregular? The rate of the ventricles, so how fast are they going? And I'm not going to touch upon how you calculate that today because I haven't got the time for it, but, you know, is it between 60 and 100, so normal, or is it brady, so less than 60, or is it tachy and more than 100? Pillage, so are there P waves present? So really thinking about that atrial fibrillation, you know, is the most common reason not to have P waves. Is it the same rhythm? So thinking about, you know, your heart blocks is what you're seeing matching up with what's coming after, and the rate, is the rate there? Again, thinking about your relationship to your P and your R's. So your P wave, is there a P wave following, you know, as a P wave followed by a QRS complex? Or if we're thinking about heart blocks, which we'll obviously talk a little bit more about next week, is the P wave not followed by a QRS complex and it's completely dissociated, so actually they're in complete heart block? Or is something else going on? Is there a P wave, as we've talked about briefly? Is the duration normal? Is it constant? And then finally thinking about the QRS complex, you know, actually, is the complex normal? Is it narrow? Is it broad? So thinking about things like that. Now, not everyone likes mnemonics, and that's fine, but it's useful to have a structure when you're thinking about looking at that rhythm and trying to understand what that rhythm shows. And this is one of many ways that you can do it. One of the things that people struggle with is cardiac access. Now, you may or may not have been taught cardiac access yet, or if you have, it's one of those things that I think often gives people a lot of headaches, and it can be stressful. So what I'm going to talk through about the cardiac access, and this is the thing that often brings people nightmares, this diagram with lots of angles on it. And essentially the cardiac access is that electrical activity of the heart starts at the SAN node and then spreads to the AV node. And as we know, it spreads down the bundle of His through the Purkinje fibers, causing ventricular contraction. And wherever the direction of travel is and activity is, the lead will be positive in that. And wherever the direction of electricity is, activity is against that, it'll be negative. And the overall cardiac access can give you an idea of the overall direction of that electricity through that cardiac access. And I'm sure at some point we've all seen diagrams like this, and it's worth remembering what a normal access is, and what a left axis and a right axis deviation is. But I'm going to try and make it a little bit simple to give you a shortcut, because I haven't got, unfortunately, the time or the scope to teach you how to measure the cardiac access properly, but a bit of a cheats way to measure the cardiac access. So a normal access, so when you look at an ECG, and we'll come on to this in a second, if you're trying to be quick and understand what the access is, if it's normal, positive, normal, left or right, you can look at lead 1 and AVF. So if lead 1 is the QRS, the R wave is pointing positive, and the lead in AVF is also pointing positive, this suggests it's a normal axis. If the lead 1 is positive and the lead in AVF, so the R wave is generally, or the general direction of that QRS complex is negative, they're leaving each other, so they're leaving each other, and this generally is left axis deviation. If in lead 1, the overall QRS complex or the R wave is generally negative, and in the AVF it's generally positive and they're reaching each other, that suggests it's right axis deviation. If they're both negative, it's a completely extreme axis, and I wouldn't worry about what that means. And so what I mean is, and we'll come to some ECGs to have a look at this now. So normal axis in lead 1 and AVF, they're both pointing the same way. So they're like that. In right axis deviation, they're like that. So they're reaching each other. And in left axis deviation, I'm not sure if I can get my hands to do that, but you get the idea, because my hands can't do that. They're leaving each other. And that's a quick way to look at the ECG and look at that axis deviation. And the axis deviation can be useful for lots of conditions just to be aware of, and there's a long list of causes of them, of which I'm not going to touch upon today, but you can have a look at those and understand those. So let me just make sure this is working. Let's just reload this. So have a look at this ECG, okay, and remember that normal, they're pointing the same way. If they're reaching each other, so they're touching each other like this, that's right axis, they're reaching, and if they're leaving, that's left. So what ECG? And I'll leave the image up there for people to have a look. If you're looking on a device, you probably will be able to see the ECG on the device. Okay, just give it a couple of more seconds just for people to to pop that in. So let me just hide the image. So we've got right, left, or normal. So let's just have a look. And it was left. So well done to those that said left. So if you look in lead 1, that's generally a leaving, isn't it? Going away. And if you look in AVF, it's generally pointing down. And look, using that diagram that I've borrowed there from the internet, generally leaving each other. So that's a left axis deviation. Here we go again. So what axis is shown on this ECG, not if shown on the ECG. We just reload the page so that it's there for you. That's it. So yeah, so just looking at a quick look at the chat box. So yeah, so this is a Cheats wave, so it's really important you understand how to properly calculate it. But this is a quick, if you're on the ward and you're having a look, looking at lead 1 and AVF. Let's have a look and see what everyone said. So we've got right, left, and normal. So well done to everyone who said it was right. So again, looking at that ECG, you can see generally in lead 1, it's positive, sorry, it's pointing down. And in AVF, it's pointing up. So they're reaching each other, they're doing that. Okay. And hopefully this last one will work. It's taken a moment. Let's just go forward and back. I might see the answer there. Don't worry, that one's not working. This last ECG, you can see this is actually normal. So you've got lead 1 where it's normally pointing up and AVF is normally pointing up, and that is a normal axis. So we're coming slowly towards the end of the presentation, I'm sure you'd be pleased to hear, but we're going to move on to checking the limb leads. So thinking about the limb leads, and the things that we need to think about is the QRS morphology, the axis, which we've talked about a little bit, the R waves and the Q waves. So we've mentioned a little bit about the Q waves and why they're important, particularly in lead 3, which is just shown here. So these very deep, very negative Q waves in the context of chest pain or ischemia might suggest that the person has newly had or has recently had an MI. And thinking about the R waves, just checking, you know, that they're present and which way they're pointing, and helping to form a cardiac access for you. Carrying on with TU and ST. So again, what you can see here is there's some ST elevation in this ECG that I've shown you here. Thinking about, you know, is that, you know, thinking about, are there T waves? Are they positive? Are they negative? You know, thinking about ischemia. What does the QRS look like? And what do the ST segments look like? So particularly in limb leads, which these are, so we're talking about limb leads. If you're thinking about STEMIs, so ST elevation MI, you need at least, you know, plus or minus probably 2 millimeters in the limb leads, plus or minus for it to be thinking about an ST elevation MI in more than one lead. So just remembering that really. The next thing really is thinking about your chest leads. So again, that ST segment that you'll learn to love or hate. And there's lots of causes of ST elevation. They're not all MIs, and that do wonky things. But as you can see with this ECG here, as you look in your screen on the right hand side, you've got that big ST elevation. If it's more than 1 millimeter in that lead and it's across multiple leads, thinking about your STEMI, so your ST elevation MI, and wanting to get that patient to the gold standard treatment, which is PCI. The other thing, thinking about T waves. So we've got T waves there again, and different types of T waves. So these are, and I've completely forgotten the name of these T waves, but these are peaked T waves. So you can get peaked T waves in a few conditions, and thinking about, what does the T wave look like? Is it a normal T wave? Is it a biphasic T wave? So it's got 2 bumps. Is it completely gone? Is it negative? And thinking about that in the context of the patient that you're seeing, what does that mean? And remembering to think about those causes. U wave. Now the U wave might be new to you, but just bearing in mind the U wave does exist, and thinking about if it's inverted or if it's bigger than your T wave, what that might mean. And once or twice I've picked up a very low potassium, so a hypokalemia, because the ECG looked a bit funny, and those U waves were very present that you wouldn't ordinarily see otherwise. P waves, gotta love a P wave. Are they there? Are they not there? What do they look like? Are they bumpy? Are they, are they doing what you're expecting to do them? And if they're not, thinking about what some of the causes of those might be. And that QT interval, which we've already touched upon, and here's an example of a prolonged QT, and remembering to calculate and correct for the QT to determine with the heart rate. So if it's particularly slow or particularly fast, the QT needs to be corrected, and I'd always do it corrected. So thinking about, in the context of, have they taken some drugs? Is this a presentation of somebody that's collapsed and you found a prolonged QT, and this may be, the cause of their collapse? And remembering that QT, a prolonged QT and a shortened QT can put you at risk of going into ventricular fibrillation and early cardiac death. Cool. So we've probably got about 5 or so minutes for some questions. I was just having a look through the chat there to see what questions we've got before I wrap up. So let's have a look. Lots of rights there. What is the significance of deviation? So somebody called Emily Clark has asked that. Do you mind asking in what context do you mean? Sorry, Emily, could you just clarify your question? And I'll try and answer that for you.
In the meantime, Sarah,
yeah.
There's a few questions that I've collated.
Yeah, that'd be great.
So a few people have kind of asked the same question. In terms of axis deviation, does it have to always be the AVF lead that you use along with lead 1, or can you use lead 2 instead?
You can use lead 1 or 2 really, and you probably should use AVF. So yeah, you can use lead 1 or 2 really. Remember, this is a cheats way. This isn't the proper way, but it's the way that all of us do it. Not to say it's right, but you do really need to know you do need to understand how to calculate that properly.
A great little tip if you're struggling in your ISCI or in any of your finals and you want to look at it quickly and find out what the deviation is, kind of at a glance, I guess.
Yeah, absolutely. It's just a glance, and it if you're being asked on a ward round or your exams, as you say, you can just go, oh yes, it's left axis deviation, but make sure you know actually how to calculate the deviation, doing it properly with maths.
Fabulous, thank you, Sarah. So another question is, what's a J point and what does it signify?
Yeah, so I briefly touched upon the J point. So the J point really is that delineation between the end of the QRS complex and the beginning of the ST. The J point is actually a controversial point in the ECG. So in the point, it's not controversial for the ECG, but actually its existence is, and its purpose is debated. The J point can fluctuate and move up or down. And basically what it's really helpful for clinically is if you've got a raised J point. So if the J point is higher than that isoelectric line, so that flat line in the middle, and then the ST segment after it, you know, whatever that looks like, what the J point can, depending where the J point is, what comes after it can help you decide whether actually is this an ST elevation MI, or is this actually something else is going on with the ST segment or the T wave after. So what it's useful for is it's giving you the context of what's coming after. I wouldn't dwell on it for your ISCEs or your finals, because I'd be very surprised if they're going to ask you about that, because that's quite sort of high level sort of postgraduate stuff. But it is worth having a look and just appreciating that there is a J point. And I think the bottom line really is the J point is that delineation between that QRS complex and the ST segment after it. And depending on where that J point sits, or if it's above the line or below the line, can help you with whatever the ST segment looks after, give you the context of whether is this a STEMI or is this something else going on, for example, if that makes sense.
Great, thank you. Someone else has asked, just kind of carrying on from the J point, is a raised J point known as a high takeoff?
It can be, but I wouldn't fall into the trap of that. So there's lots of reasons to have your J point high. So you can have a high J point and then the ST segment is high after it. And that might be a STEMI, that might be because of pericarditis, that might be because it's normal. So I wouldn't dwell on that. It will come with a lot of practice of seeing a lot of ECGs to know whether that, and the context of the patient that you're seeing. And I think obviously I've walked you through the whole of, you know, I'll give you a flavour of some of the things to think about with ECGs, but actually you need to, the ECG is only relevant to the patient you've got in front of it. So it's bearing that in mind. Don't look at the ECG in isolation of the patient, if that makes sense.
Great, thank you very much. So continuing from Emily's question earlier about the significance of axis deviation, we've had a lot of different healthcare professionals, not just medical students, joining us tonight. A few paramedic students, as well as some physicians associates, you know, advanced nurse practitioners. Great to have you all. Thank you for joining. So Emily is a paramedic, and she wasn't too sure about how axis deviation would affect her patient. Would they need hospital admission or GP follow-up if the axis was abnormal?
So I think for our pre-hospital providers, I think the axis deviation on its own is not enough to necessarily hospitalise someone, because you can have an axis deviation and it be absolutely perfectly normal. So I wouldn't dwell on it. The axis deviation, again, like everything with the ECG, is in context. So, for example, some of the causes of left axis deviation are things like left ventricular hypertrophy, so big heart, basically. But from a pre-hospital point of view, no, it probably won't change anything. From an in-hospital point of view, again, it's context. And whilst it's not the thing that will clinch the diagnosis, because you will look at the whole ECG, it can help guide cardiologists and physiologists as to where location of things might be going wrong. But it's not enough to necessarily hospitalise someone just on that.
Great, thank you. So we're going to kind of wrap up some of the questions at the moment, but one of the questions we've had, this is quite a controversial topic, especially in emergency medicine research at the moment. Someone has asked, are the ECG analyzers always inaccurate in the emergency department?
Very good question. So there's been some research about this, and I've read the research. So the rule of thumb is, so the research suggests they're not 100% inaccurate, but the rule of thumb is that actually, I'd assume whatever they print is wrong. And the reason being is, after I've now been a doctor for 10 years, And I've worked in emergency medicine for 7 of those, and I've been referred a lot of ECGs from a lot of different people, and I've seen a lot of ECGs from a lot of different people who have just used the analyze box that's on the top of it. Lots of things will affect the analyze box, and I've been referred patients with STEMI, who are 17 years old with no chest pain. So it's always going back to the basics of having an understanding and appreciation of the ECG, have an appreciation of what the basics are and really understanding it. And I always say to my juniors, don't necessarily, don't rely on what that analyze box says. ECGs are getting better, and I know there is some research that suggests, they're pretty accurate, but actually they're only accurate if you know what you're looking at is accurate. But I wouldn't rely on them. I would always rely on your own interpretation.
Great, thank you very much. So we'll kind of wrap up the questions there. Thank you everyone that sent through the questions. What I'll do is I'll collate some of the questions that haven't been answered tonight, and then we can send those over to Dr. Edwards, and she can have a look at those and potentially cover a few of them in the next session, which will be next Sunday, the same time at 7 p.m, where we'll be going over the second half of ECGs on some of the common pathologies that you might see in your medical finals at our stage. So don't worry if they haven't all been answered. I will collate them all and make sure none of them are missed, so don't worry. So just before I hand back to Dr. Edwards, I'm just going to send the feedback form in the link now, or in the group chat, sorry. So this, if you fill out this, you will very soon afterwards get your certificate for attending tonight. So thank you so much. As well as that, we'll be sending over these slides in a couple of days' time, just so that you have this to look over, and the recording as well will be shared at a later date as well for anyone that's missed it. So if you have any colleagues that could make it tonight, you can let them. So that's going out now. I've just sent the feedback form. So please feel free to fill that in. Any other last words, Dr. Edwards, at all?
Oh, right. So so in summary, I think in true educational style, so we have in ECG part 1, we've talked a little bit about the anatomy and physiology. We've talked a little bit more in depth about actually what the ECG looks like, and we've talked a little bit about the structure of how you might interpret it. I think in context, so if you want to get in touch with me, I'm happy for you to tweet me, Instagram me, email me, I don't mind. I'll try and answer them, or go through Zoe and what have you, so that's absolutely fine. And then hopefully in part 2 next week, we will wrap some of these up, and I'll show you why knowing all these basic points is really, really important clinically. So I will leave it there. Thank you very much, everyone.
Great, thank you very much. I'll just stop the recording.